The next live surgery is of a 25-year-old female who presented with complaints of dysphagia to both liquids and solids for the last 5 to 6 months. She also gives history of significant weight loss and history of nasal regurgitation and recurrent upper respiratory tract infection. The upper GI endoscopy showed grossly dilated sigmoid esophagus and a tight OG junction. The barium swallow shows classical bird-beak appearance at the OG junction and grossly dilated esophagus. Manometry of the esophagus showed features suggestive of type 2 achalasia. Hence, the surgery planned is laparoscopic hairless cardiomyotomy. Operating surgeon is Dr.R.Parthasarathi. Assistant surgeon Dr. Manoj. Scrub nurse Mrs. Saudeshwari, Miss Yamuna. Anesthetist Dr. Manju. Anesthesia technician Mrs. Radha and Miss Chandini. Handing over the mic to Dr. Parthasarathi.
Good morning. Good morning, sir. And this is a fourth case we are showing live. And this is a hairless cardiomyotomy. It's a young female. For past 5 months, he was suffered with not able to for solid and liquid diet. And we are planning for hairless cardiomyotomy. And I'm like to show the code. And this is the team setup. Team setup, you can see patient is modified Trendelenburg abductor leg. I'm standing between the legs. And my camera surgeon on the left side and my staff nurse on the right side. And she is here for interacting the liver. So this is the monitor is in the head end of the patient. So this is the team setup. And I'm going for cam 4. So this is the laparoscopic camera is good for showing the port. So the surgeon's view can be applied. Yeah. So this case you can see usually 4 finger breadth above the level of umbilicus. I go for camera for even in fundo and atlasia. And this case, even if you want 1 centimeter above is ideal. Since the costal margin is very narrow costal margin, no, that's why I made like this. It's a 4 finger breadth from the umbilicus. And after making this, I made this port. You can see the costal margin here. It's a bulky shape. So this is my right hand port in the mid-clavicular line. Usually the stomach, the greater curvature curve like this. So that place I made this one. After making this, I retract the liver and then I made this port. And it is so this is the midline. This is the midline, and this is little right of the midline. Now come obliquely so that it will no retraction is easier. So this is the left of the midline in the upper epigastrium or subxiphoid. And coming to my left hand working port in the right midclavicular line, it is compared with this port. This is the camera. Usually people will make it here. So that means my hand is like this. I have to work. And now you can see my hand is like this. So it should be a little closer to the camera and little lower down from this upper port. From this right hand port. Right hand port, if you draw a line, it is here. You can see it is almost 1.5 to 2 centimeter down. And the distance between this is little less. So almost this is only 3 fingers. So like this, if you made it, so your left hand movement is it need not to be abducted shoulder. And this is the left lateral port. It is an anti-axillary line. This is for retraction of the stomach when I mobilizing the esophagus. So this is the standard port for any upper abdominal surgery, fundo, achalasia, transabdominal esophageectomy, or any esophageal mobilization for malignancy, IULs, or thoracolapse. So this is the standard port. So is it clear, sir? Ports? Anything to be discussed in ports? Oh, okay. So I'm going it inside. Yeah. Okay. Thank you, sir. So I'm taking a camera inside. And this case, I'm using a Smith Review Company 4K camera. And here I'm having a 55-inch screen. The video is clear, no? Your side? Okay. That's maybe. Okay. Maybe the local internet may be the problem. And so this is the what is put the camera. And you can see my camera is in the left of the falciform ligament. This is the falciform ligament. And I enter left of the falciform ligament. And this port, the left hand port, and you can appreciate I'm coming through the falciform. So otherwise, each and every time when I take the instrument, when I go with the instrument inside, falciform will hidden, obstruct, so that I take the instrument trocar through the falciform ligament. So I am taking the liver. This is the liver retractor, and you can see like this. Okay. So if it is coming vertically in the midline, so it will be like vertical holding. So this will be bulk. So that's why we are coming little obliquely left of the midline. Left hand instrument. See, this is my left hand instrument, and I'm coming. This is my left hand instrument. This is the right hand, and you can see even if you put the angle is little height, this is little low. And this is the left lateral port. You can see it's coming down. Left lateral port for retraction of the stomach and during time of mobilization. So first thing is I have to mobilize the esophagus. This will be like any bowel holding with the locking is ideal. This case there is no lock is there in this case particular. And you can see I retract the stomach towards the left side, come pull down towards the caudal and then left. So that the gastrohepatic momentum is exposed. And this is the mostly achalasia, long standing achalasia will be thin patient. And nowadays it is getting thin patient is very rare. Now, most of the patient is bulky. And this is the hepatic branch of vagus. There is no vessel is there. Sometimes if it is a vessel, we will preserve the vessel. I'm using harmonic HD, and all of you know it is a very sealing effect is good, and any advanced procedure HD is better. So you can see the attachment of the gastrohepatic up to here. So I'm going to see the attachment now. Camera lever hold like this, so that it is stretching, so that my instrument will not touch the crust. Okay. So only the gastrohepatic is open. And I'm telling you how to mobilize the esophagus. It's very, very easy basically. People are now, they take long time. So after, once the gastrohepatic is open, you can see the caudate lobe and right crest of diaphragm. And esophagus will be here. And you have to see, this is the left gastric vessel. We need not to start from here. So you have to start from here. So you can see the right crest, and then the edge of the right crest is seen here. So I'm just opening the peritoneum alone. Since it has a very long thin blade, it is easy to take the very finer tissues. And if you should not hold very thick, the vagus will be here, posterior vagus will be here. So I'm opening only the peritoneum. Very thin way. Should not open this peritoneum. So this will, when we do the crural repair, this peritoneum is required. So I'm opening only this. Then I'm creating little bit space here. Can you see? Close up, focus. Peritoneum is open, and I can able to see the median arcuate ligament. See? So I'm not dividing the other tissues, just the retraction I'm making it. So after, so I'm create the retroesophageal window little bit, and now I'm holding the right crest. I'm holding the right crest. Esophagus traction is there. I'm just ensure that it is adequate traction is given. So I'm holding the right crest. So just I'm pushing the tissue. Hold the right crest. Now this is the border between the crest and esophagus. This is the border. So I'm just opening the, just cut the peritoneum. I'm not no cutting any tissues. Just cut the peritoneum. So again, hold the left crest, right crest, push, push, push like this. Traction push. Hold the tissue. Again, push like this. So now this is the esophagus. This is the right crest. And I told you, when you are starting here, the vagus will be coming close. So you can appreciate vagus will be here. Can you see, sir? Vagus? Hello? Yeah. Yeah. The vagus, you can see, it is not on the right crest. And I'm going a little bit inside. So this is the left crest. This is the right crest. Always right crest will be straight line, little bit thinner. Left crest will be obliquely placed. You can see it is thicker. And it is lying on the left crest. Both the vagus is lying on the left crest. So I'm just pushing down. And always during a mobilization of esophagus should not be held with any instrument. So that is a dictum. So now I'm holding the right crest again. I'm just taking the peritoneum. Just a very thin peritoneum we have to take it. So now again you can see the right crest end here. This is the phrenoesophageal membrane. It starts from here. It is going like this anteriorly, then lateral, and then it ends here posteriorly. So I am going to demonstrate the phrenoesophageal. Usually achalasia, no, all case we used to do. So now you can see I am doing this. One small thin tissue layer is there. I have to take down this layer. That is the right pleura. What I'm holding with my left hand now, this is the right pleura. So I have to be careful. So always when you go dissect anteriorly, you can see I hold the tissue with my right hand harmonic. Left hand I'm pushing down the esophagus. Pushing down the esophagus. Can you see this vagus, anterior vagus? Yeah, that is anterior vagus. So I'm pushing down. So now this is the phrenoesophageal membrane. I'm cutting it. So without doing this, you will definitely injure the nerve. And this is the left crest. That is the left crest. So again, I'm coming down. If I cut here, I will cut the left crest. Yeah, this is the vagus, anterior vagus. So always hold that tissues with the right hand. Left hand, you just press down, press down, press down. Now, can you appreciate? This is the left crest, and this is the phrenoesophageal. So now I'm cutting the phrenoesophageal. I'm protecting my left hand instrument is protecting the vagus. See, that is the this is the vagus. Now you can see both is very closely lying. So that's why hold it, press down, confirm vagus, then cut. No, we cannot repair it, and we should not. Posteriorly, if we cut the posterior vagus, secretory effect, anterior vagus, the motor effect will be gone. And most of the time, we can manage. And olden school teaching is if you cut the vagus, we have to do gastrojejunostomy. But it is not like that. We can even some of the no, my residents, they are doing it. Sometimes they injure the vagus. But I observe that, but nothing is happening. So now this is the left crest. So you can see my left hand instrument not opening, close, and I know that this is the vagus now. I keep my left hand over the left crest, and then along with the vagus, I lifted the esophagus. Can you see this? Yeah, I lifted, and this is the phrenoesophageal membrane. Can you see, sir? Membrane. This is the membrane, phrenoesophageal. So I start from here, going like this. Laterally, I divided. You can see this thick and divided end, and then coming like this, and then attaching here. So now I am dividing phrenoesophageal, and my vagus is protected with my left hand instrument, so there will not be any issues. So this is the thing. Once you divide this, then only your posterior window is, retrocerebral window is complete. You can see automatically it is opening. I created small window. I am not extending. If you try to extend, I will injure all these vessels. So initially make a small window, then go around, divide the phrenoesophageal, then automatically entire window will get open. Can you see it, sir, now? And small tissue still it is there. Okay. See, so much attachment of phrenoesophageal is left hand. So now there is a small any attachment is here. I am dividing it. These are all only flimsy tissue. This is the left pleura. Left pleura. Most of the time, left pleura is will come very down. So if you mobilize the esophagus, left pleura injury is the common than the right pleura injury. And always, if you are dissecting any, dividing any structure, and we have to see the small vagus nerve is there or not, then you divide. And if you want to dissect more, you can do it. Depends on your purpose. And if it is a dilated esophagus, I want to go a little bit inside, so I have to mobilize the esophagus well. Hold this. So it took me around 10 minutes time if you are in a right place, 5 to 10 minutes. So the airways is mobilized. So I want to go some more. I want to dissect some more area. Go to non-dilated portion. I have to do the myotomy. So I'm going now. I hold my pleura with my left hand. Hold my pleura, and then I'm dividing it the pleura, dissecting the pleura from the esophagus. Can you see that here? Yeah. So this is always no vagus. You have to be careful. Any structure you have to divide. You have to careful. See the vagus now. That is very important. So laterally always what I know, I go laterally right side first. Little bit down, and entire hiatus is occupied with the by the esophagus, dilated one. So I'm going anteriorly now. These are all loose areolar tissue. More no vessel will be there. Now you can see the pleura is there anteriorly. So I want to go myotomy up to that level. No, normally the recommendation is 9 centimeter of myotomy. My preference is not 10 to 12 centimeter. I used to do 9 centimeter in the esophagus itself, and then totally it will be like 12 centimeter or 10 centimeters. And again, you have to see the vagus now and then cut. Don't cut all the tissues. Vagus should not be included. So like this, dissect, then cut. Push the structure, then cut. What I do, I can take this liver retractor inside the mediastinum. Hold this like this, sister. So that will give a very good access. Slowly, always you can see my instrument left hand is I open and then I push the esophagus down, and then I'm pushing the other structures away from the esophagus. I'm not holding the esophagus during the dissection. See, it is nothing is there, only the fiber. So I can cut. So always careful about the vagus. So once you cut the small vessel, then you will get around the 1 centimeter length of the dissection. Vessel is the one is holding the tissues. Yeah, come out, come out. Can you see how much I dissected? Midline one, midline, full one. Yeah. So anteriorly dissection, because anteriorly my dissection is my atom is going like this. That's why I'm dissecting anteriorly. Yes, sir. What is the question? Usually, for traction, we used to put a tape and then we can pull the esophagus. But for achalasia, I don't do this, sir, because I'm going to do myotomy. There will not be any congestion here. For a fundoplication, I can do that. So normally fundoplication, I put a tape in the OG junction and then I pull the tape so that I can dissect the esophagus. But for achalasia, I can manage with this, by holding the instrument itself. So now I coming posteriorly. Again, the pleura, I'm just pushing down. And this is the thoracic aorta. This is the thoracic aorta. Posteriorly, that much is not required. Normally, for fundo, I used to dissect posteriorly because my dissection is going only anterior. Just I'm demonstrating. And almost I completed the mobilization. Right crush, left crush, and this is the aorta, thoracic aorta. And this patient had little bit mild, right side, sigmoid configuration. It just started. So that's why I am trying to mobilize this right side more, and I'm making the esophagus straightened. That will help a lot, when we are patient is dysphagia. Okay. So now you can see the exposure. So the right side sigmoid configuration, I'm trying to make it, straight. No, it's from OG junction, it should be around 7 centimeters. And even 5 is enough. From OG junction, 5 centimeters is enough. And I can go up to 7 routinely. So again, pleura is very closely adherent to esophagus. Can you see, sir, some roomy space because of the dilated esophagus on the right side, and I'm not able to hold the. Yes, which one? Yeah, I'm inside the mediastinum. Yeah, inside well, almost below the heart. I'm dissecting now. So this is because of I want to straight the esophagus. Yeah. So I think it's enough now. It is looks now. It is coming. It's like straight. Yeah, yeah. This is the dilated one. Starting from here itself, it is dilated. Here itself is dilated. And next part is I have to mobilize the vagus now, anterior vagus. Usually it starts on the left side on the left crest, and then it crosses the esophagus in the OG junction. And when I do myotomy, it will come in between. So I have to mobilize the anterior vagus. So for that, I started from the lesser curvature. So this is a chemostatic, good chemostatic device. I'm using a chemostatic mode. This is very important, sir. We have to take out the fat covering the OG junction. Please, sir. So when we take this fat covering OG junction, so you can see I'm taking one layer. Can you see appreciate here? I saw that maybe after dissection you will appreciate more. And here you can see the bared adventitia. Here some layer is covering. We are not seeing the straight longitudinal muscle layer. You can appreciate the longitudinal muscle layer here. Okay, that is another trick. No, another tips and tricks so that you can separate the longitudinal muscle easily. I'm going one layer down. I'm taking the adventitial layer, and you can appreciate this is the vagus now. When I pull, you can see that is the vagus now. So, and also I'm not holding the vagus. You can see vagus going deep. I'm just holding the superficial structure, and I'm taking the covering layer of the longitudinal muscle. This is the layer, sir. So now you can find the difference. You can see the longitudinal muscle here. That layer is covered. Without taking this, if you split, no, this layer is thick layer. You will find very difficult. So come out. So these are all the things we learn slowly by each case, so that nowadays it's become standard. So in my unit, all surgeons, no, for three surgeons is me. Uh, Ramesh is surgical guest. So all Ramesh and Sarana Kumar, Bharat, all the entire team is doing all these surgeries. Even all gastrectomy, esophagectomy, everybody share our work and everybody is doing equally. So along with the neurovascular bundle, now I'm taking it, and they have to see post-vagus is here. We are not disturbing the thing, and I'm skeletonizing the anterior vagus from the esophagus. And again, I'm confirming it. You can see that is the vagus. So here it is crossing. So my myotomy is coming like this. So it will disturb me. So I'm taking this out. So this is the first tip when you are taking the vagus. Myotomy first tip I tell this is the one. If you're not taking this adventitial layer, covering layer, then we'll find difficult. Now you can see sir, esophagus is skeletonized. So my myotomy is going like this. We should not hold the vagus. You can see I'm just covering fat. I'm just holding like this. Okay. So almost 7-8 centimeters from OG junction I dissected. Vagus is other side is free now. Come here. Okay. That is the positive value. That is the positive value. Yeah. So now I'm going to before myotomy, I have to finish all the steps. So after myotomy, there is two type of fundoplication. One is a two-pay. We take the fundus cover like this, and reflex control is better in a one is a door. This is the door anterior fundoplication door, and my preference is two-pay. I take the posterior. That's why I dissect the posterior window. So I have to take this fundus posteriorly. So I have to no mobilize the fundus. Don't start from well down. Only one or two short gastric division is enough so that postoperative the gas bloat syndrome will not be there. If we skeletonize the fundus more, then the patient may have some no, bloating sensation. Hold this. So now I enter the lesser tract. This is the posterior wall of stomach. So this is what we have to go. Once the posterior wall is exposed, that hold the posterior wall with the left hand, then your division will be easier. See now. So that is a vessel. I hold it very close to the stomach. So always the hemostatic, no, the harmonic blade will be hot, 80 to 100-degree temperature will be there, touch the tissue, because I don't want to touch with the stomach wall. So I'm going again, close up, again touch the momentum, pull the blade. I'm shifting my instrument deep to the fundus, hold it. The posterior is no 180-degree two-pay fundoplication. So that is the first short gastric divided, this is the second short gastric. So for this peritoneum to be divided first, so here. So now it's ideal. So we should not give any traction. And if it is a bleach, then it will retract, it go close to the spleen area, then finding difficult to coagulate. So that we have to be careful. And if a regular harmonic, we can keep it in level 2 so that the sealing effect is better. So I divided only two short gastric, and now I almost after this the fundus will be free. And the idea is the entire left gastric left crust to be now seen well. That means your fundus mobilization is adequate. For Nissan, we need to dissect some more. And two-pay is now only 180-degree. So now you can see the left crust well, entire left crust. And if you go beyond like this, you may come to the splenic vessel also will come. So now the fundus is mobilized. So I'll keep the fundus here. So I hold like this. I have to confirm whether the fundus mobilization is adequate or not. So I'm keeping here. See, this is the anterior wall of fundus. This is the anterior wall. So this is the anterior wall. This is the posterior wall. So the posterior wall should be on the right side, anterior wall with the left side. So after myotomy, I'm going to have this fundoplication, and you can see it is Susain, it is a maneuver. And when you are doing a Susain maneuver, what is the observation to be done? And people will tell that okay, it is moving. It is not observation. When you are doing suicide, esophagus should not rotate. If it is rotate, some posterior attachment is there. So when you are doing suicide, you have to see the esophagus that should not be rotated. So I'm making a two-pay like this at the end of the surgery, and when I leave it, it is staying here. It is not pulling going to the left side. That means mobilization of fundus is adequate. Yeah, yeah. So I'm just telling that it is an anterior wall of fundus. This is a posterior wall fundus. I'm taking posterior wall here. I'm leaving it. You can see it is staying. It is not going back. That means your fundus mobilization is adequate. Second thing is, and when I do the suicide maneuver, when you listen, so when I do the suicide maneuver, the esophagus should not rotate. So now I'm doing the fundo application like this. So it is adequate mobilization of fundus. So I'm going for myotomy now, and I have to see whether this is too much. I have to make a narrowing of this hiatus. Yeah, pleuroplasty, and esophagus lies like this. If you narrow like this, it will be like hooking, tenting of esophagus. So what I do, if it is want, I can do one suture here, anteriorly. Gas piece first. Gas piece. Yeah, yeah. So I'm just taking the gas piece inside, and when myotomy time, yes, sir, yes. Yeah, yeah. I take a gas piece inside. For myotomy time, any bleeding, any small, bleeding, gas piece will be helpful. Okay. No, it is depends on the surgeon's preference, and always my preference is to pay and to pay. That is the reflex control is better, even though no studies shows equal, but I feel practically we are seeing that is better. And second thing, when you feel that a mucosal injury, you see sometimes any mucosal, you are making small injury, or you feel like cautery is touching me, or something is there, and then you can do DOR. So the DOR will be like a mucosal patch, so that it will take care of the micro perforation. So post of that is another reason many surgeons are started doing DOR. Hold it. Initially, DOR is easier because you need not to mobilize the posterior, no esophagus. You need not to mobilize this window, and only mobilize the esophagus anteriorly. Then you can go for DOR. For beginners, it will be definitely easier. Good. Yes, sir. Monopolar. Okay. Oh, thank you, sir. Yeah, thank you, sir. Yeah, Joby. Okay. So I'm. You can see this is the OG junction. I'm lifting the stomach. This is the OG junction, and I'm not starting at the level of OG junction. Here the crisscross fiber will be there, and I'm starting my myotomy above the level of OG junction. Okay, then I'll come to the OG junction level, and you can see two-hand curved dissector. I'm holding. This hand is also curved dissector. A diathermy is attached to my right hand. This one, and I'm just my first initial step is I find out the midline of the anterior midline. Then I'm opening the just splitting the longitudinal muscle. Can you observe? Setting is usual. 25 coagulation is adequate. How much now you have? 35. Okay, anything is okay. If I feel more, then I'll reduce it. So, and mostly monopolar requirement will be very less. See, I'm just splitting the longitudinal muscle. So I'm splitting the longitudinal muscle. That is helpful, helping a lot. So now I'm turn the curve like this. I'm not opening like this. If you open, I'll injure the tip will injure the mucosa, even though it's a blood tip. I turn like this. I just press down the mucosa with the instrument, and then I opening like this. Can you see this? This surface, no, this curved surface, holding surface. I'm using to press down the mucosa, then I open. Is it clear, sir? Yeah. So I'm opening like this, open, open. Can you see the mucosa down? That is the circular muscle. See, this is the longitudinal muscle. Below is the circular muscle. So now I'm going, I catch the circular fiber. I'm going to apply little diathermy. So I'm separating it. Okay. Just I'm showing it again. So I open the longitudinal muscle. I open the longitudinal muscle. Then I enter here. Down is the mucosa. This is the longitudinal. I'm separating. So now what after that what you do? Another simple way is I'm not concentrating the circular muscle now. I'm just separating the longitudinal. Can you see here? And Palnivel sir is designed a scissor, with the lower blade covering, cautery protecting scissor, modified sugar baker scissor that will be helpful. But very thick muscle is there that will be help a lot. Otherwise, even a regular way we can do that is enough. So you can see I'm separating the longitudinal muscle. That is a 10 mm, even 5 mm and 7 mm they are making. So now the longitudinal muscle is divided, and is I push the vagus on this side. This vagus is straightened like this. So now I'm going for a circular fiber. So I'm just doing like this, dissecting, hold the circular fiber, separate. Okay, dissect, dissect like this, hold, separate. Very thick circular muscle fiber. So dissect. So that is the circular. Can you differentiate? No, sir. This is the longitudinal. This is the circular. Very minimal cautery. So I am dividing the muscle. This is the myotomy. Need not. People are using harmonic and other thing. That's why I told you this the anterior covering layer to be removed when you are taking down the vagus. That is the point number one. Point number two is mobilize the lateral longitudinal muscle to be separated first. You can see I'm separating it longitudinal. Then third tip is use this this blunt tip, curved tip instrument, and to press down the mucosa and down. You can go separate like this. Then hold the muscle, just tear it. If you find bleeding, coagulate. Otherwise, no need for coagulate. When you see the mucosa, it is bulging. It should be bulged. And again, I'm going up. Esophagus traction repair system. Always the esophagus traction is important one. So we have to. And this is the one step you have to do very carefully and very slowly. Yes. Yeah. This if it is a very thin, I don't coagulate. So, so I'm just tearing it. If it is not possible to tear, that means some vessel is there. So I'm tearing, I'm not coagulating it. It is easily separable, I don't coagulate. If I'm not able to separate, then that means some vessel is there. Then coagulate. And another small tip, fourth tip I want to tell you, when you're doing myotomy, you can see one thin layer is coming here, and I'm going above this layer. So that is the submucosal layer. Yeah, 7 centimeter on the esophagus side, 1.5 to 2 centimeter on the stomach side. So 9 centimeter myotomy is the criteria, should not be less than 9. 7 is a no rule. 5 centimeter on the stomach side, 5 centimeter esophagus side, 2 centimeter stomach side. In case of dilated esophagus, then I do little more, because dilated esophagus peristalsis will be low, so the myotomy will helpful. So since I expose the very length of esophagus, so here I am applying cautery outer layer, longitudinal outer layer, and here the adventitia also will be there. Traction system. Yeah, it is 5 centimeters. So usually the tip of the instrument and the Karlstorff scale, this length will be 5 centimeters. Okay. No, stomach side I'll go 1.5 or 2. Mostly 2 centimeter I'll go. Since I'm doing a toupee, so 2 centimeter is ideal. I will not produce any reflux, because toupee reflux control is good. And if you are doing a door, then 1.5 is enough. So I'm just tearing it. So it is coming. I'm not applying any diathermy. Again tearing, no diathermy. Again tearing, no diathermy. Again, no diathermy. No diathermy. Can you see this, sir? So why it is now it looks little bit simpler. There is the three things. One thing, when I take the vagus, I remove the layer, covering layer, so that longitudinal muscle is seen nicely. Then first I just separate the longitudinal muscle, then I go for a circular muscle. Don't do both together. So sometimes our tendency is dissect like this, take a harmonic or try to cut together, then you will be in a problem. So always, so everything is now by learning slowly. We are also in learning phase. Each and every surgery, you think that you are doing a first time, then only you learn something. So this is the layer I told, no, the adventitial covering layer. This has to be separated first. Here it is not separated. You can see it is separated. Then I am coming for this longitudinal layer. Usually I went around 2 to 3 centimeter on the dilated portion of the esophagus. So I am doing a longitudinal portion now. Longitudinal muscle is divided. Gospies, yes, compression. So now I am coming for circular. You come back. No, I don't do routine endoscopy, because the myotomy is, we are seeing laparoscopically well, and endoscopic confirmation is no need. I do the Riles tube I pass, and then I do the leaking test, air leaking test. Normally, I don't do endoscopy. So now up to here, I separated the longitudinal, and you can see the circular muscle. It is very thin muscle. It is not a thicker one. Once you separate, it will become a thin. So I'm not at all using a diathermy to separate the circular muscle, because I told you, all the vascular layer is up. I separated. Most of the time, the circular muscle will not be have much bigger vessel. Okay. Okay. So now, next thing is, we have to hold the divided edge of the muscle, this side and this side. We have to pull like this, so that the entire anterior part of the wall of the esophagus will, and mucosa is open the entire anterior side. Okay. So now, yes, yes. Okay. Yeah, yeah. The Botox, yeah, yeah. Botox plastered. Yes, yes, yes. Yeah. So Botox, yes, sir, yes. When the patient had a pneumatic dilatation, and initially we used to tell when the patient dilatation means mucosal injury, then you find difficult. It is not like that. I have operated many patients with a pneumatic dilatation. I'm not feeling any difficult. That is, yeah. And Botox, definitely some fibrosis will be there, and most of the time we can able to manage, and slowly we have to perform. We can able to manage because mucosa is a thicker one. It regenerates. Just fibrosis not making our any issues. And here, when you come to the OG junctions, now I'm see you are seeing that again. I'm separating the longitudinal fiber. Yeah, longitudinal fiber. Here you can see some crisscross fiber will be there. Suction. So now I'm taking a suction to make the glass piece dry. Suck. So the glass piece is wet. So suck, 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 suck. Okay. Suck. Because but Maryland is ideal instrument for myotomy. Eh? So here you can observe the crisscross fibers. Eh? So I'm not doing, no, I'm not inserting my instrument to separate the mucosa here. I'm just separating like this. Eh? Hold the muscle fiber and then pull like this. So these are all the fibers. I'm just holding. And mucosal injury very common in OG junction and on the stomach side, not on the esophagus side is not much common. Yeah. So I'm coming here again. Hold. Yes. No, no, no landmark, sir. It is our assessment only. So now you can see this oblique fiber. No, that is there, but it is not always. And what I do anyway, if we pull this stomach like this, we know OG junction started here. So 2 centimeter. If you come from OG junction, 2 centimeter, not from upper border, lower border 2 centimeter. That is enough. Yeah, here also crisscross fibers. I'm not dividing it. I'm just you can see. I'm just holding it. I'm doing slowly. Can you see this separating? Yeah, yeah, that is different. No, here circular. No, just pushing like this. Yeah, that's why I make this gauze dry so that it will be shown very bloodless feel. Here fibers are very thin, and if it is not separating, when I hold the tissue like this, pull like this, it is not separating. That means that is a weight. We should not pull too much. Can you see this? It is separating nicely. Very gentle way. No, we should not hurry. So previously I started from here above. Now this much I have come down. Eh? So again, I'm planning to come up to this level. As he tell that way, and to this fibers I can apply cautery. You can see when I hold, I'm not holding like this. Eh? Very thin means not tear, bleeding. See, turn, hold like this, thick. The same way here also turn, hold like a sticker, like this sticker way, then slowly separate. Almost all the tip I learned so far, I have told. So I think it will be very useful for the younger surgeon. Yeah. So that small bleeder is no need to coagulate, just give some compression. That will be enough. More stomach side dissection will make the reflex tendency more. So this is the muscle fibers. I'm just holding it close up. Yeah. These are all very not a strong muscle. It is just if you tear, it will come out. Only thing, no, it is not opening. That's why the patient had this failure. Suction push. Suck, 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 suck. And always in laparoscopically, initially the first surgery lap poly is now they're telling that gold standard, and second is the Hellas cardiomyotomy is a gold standard technique. So we have to do carefully and compare with the poem. Here the reflex control is so good. So now it is the OG junction. I'm not if I pull traction, it will become a more. If I leave it, now I'm checking it. So from here, it's almost now 1.5 is there. I have to make some more, little bit more is enough. Yes. Yes, sir. We are getting many patients with dilatation, but nowadays it's not much. The patient awareness is more. They are trying coming for surgery, and we are getting less only. It is not frequent. I can say it's not frequent, and maybe once in 6 months, like or one 10 achalasia, one will be dilatation like. No, no, no difference. Pneumatic dilatation, no difference. Only the Botox, few patients, I operated only few patients. Find a little bit difficult. That is also we can able to do the myotomy well. And pneumatic dilatation will not produce no difficult myotomy. Recurrence we are not seeing much. Only a few cases, that is the sigmoid esophagus cases, we had a recurrence. For these type of cases, we don't have any recurrence. Sigmoid esophagus 50-50. 10 patients means 5 patients will come with recurrence. Then we go for a esophagectomy, very dilated esophagus. That is basically myotomy is open, but esophagus is not contracting. So this regular case, no recurrence. Yeah, that we are seeing nowadays that early achalasia mimic like GRD, early achalasia. Even now I have one patient. I'm just did minimal dilatation and then I send home. This is Diwali time. That patient undergone fundoplication, early achalasia, but it's outside done fundoplication. He came with dysphagia for liquid, for even water. Then he thought of a very tight wrap. Initially, I thought like that, but the investigation shows it is a endoscopy shows it is a very loose wrap. Then it is a early achalasia. So like that, now initially GRD we have to work out nicely. That's why all GRD patients posted for fundoplication, I am doing a manometry. That is very important. Do manometry, then you go for a fundoplication. I'm going to show you the length of the myotomy by keeping a umbilical tape. I'm going to take a 10 centimeter length. Then after that, I go for toupee. No. Just for demonstration. No, it is a. I don't tape the esophagus. Just holding is enough. Just length of myotomy. I think even by visual itself, it is adequate. The toupee. Toupee. Door is like this. We have to do toupee fundoplication, posterior. So that's why, yes, compared with door, it is less. So I'm going to not suture these fundus. I'm going to take three stitch like this post wall fundus here on this esophagus, like this three stitch, and then this wall, entry wall, again to esophagus three stitch. So that will be a two-pay fundoplication. After that, I'll put only one stitch here anteriorly. Posteriorly, I'm not doing any stitch in this case. Dye test. No, I do yearly test. Yearly. Yeah. Yeah, I'm going to do now. So this is the tape, 10 centimeter length. So almost I can say it is 9 to 9.5 centimeter I have done. Yeah, it is adequate. Yeah, even 7 is adequate. Yeah. Suture good. I'm going for toupee. I'm taking a ethibond suture. Yeah, any absorbable, non-absorbable, you can use it. And we feel this is very ideal. No multiple suture we can make. Even proline 10 proline is good. No need for one proline. But here the needle is very thin compared with proline. It is a thin needle, so that easier to manipulate. Number one. Number two, that thread is also very good thread compared with proline. No, this is good thread. Memory is not there. Yeah. I don't use no curved. We can use it. This one self writing. I don't use it. Self or curved is anything is good. So this is 2-0 ethibond, non-absorbable. This is a polyester suture. Polyester suture. So I'm going to take the advent serosa. Serosa, see, like this. And then stomach posterior wall. Here there is no memory. Proline is very good memory, and here ethibond is very poor memory. It won't shown at all. It came out from the sulcum ligament. Now the traction of esophagus is no need, so I'm fixing the instrument here. Just 3 suture in a 1 centimeter distance is enough. Totally 6 sutures, no, both sides will hold the stomach, and it will keep on, widening the pulling the edge of the divided muscle so that again in, uh, muscle joining will not be there. Two page this part is missing, so that is a C loop. This is the reverse C loop. Sorry, before this QK, I have to check the air leak. If it is a leak is there, I convert to a door. இது பரல் டியூப் உள்ள தள்ளுங்க. I used to push down the Ralph tube, and if you feel any injury, then you can go for a door. Slow push பண்ணு, பார்த்துட்டே பண்ணு. See, it is coming. Go, உள்ள போ. Yes, yes. Go, 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 go. Okay. So I occlude the stomach like this. I make the table head down. Okay. போடு யார் போடு. பண்ணு பண்ணு பண்ணு. Okay, okay, okay. Now we put a yes. So it is bulging. Can you see? There is no air is coming. Okay. Tuck பண்ணு. Minimal air is enough. It's much distended this case. Tuck, 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 tuck. Okay. This can be taken here also if it is coming in our way. And we should not take the mucosa. We have to be careful. So here I'm showing you one small trick. Uh, when you are doing knotting, sometimes it will become a loose. So, so I'm making a knot, the sergeant knot, double knot, half knot. I am purposely making it loose. See, it like this, like this. Suppose if it is a loose, just I'm so knot is loose now. So I'm making a this is a C loop, the reverse C loop. Again, I'm making a knot. So it is so knot is tight, but suture is loose. Close up. Can you appreciate, sir? Yeah. So suppose if it is happened like this, don't cut the thread. What you do, you can this is a square knot. You can convert into slip knot. So I hold the long thread with my right hand. I'm holding a long thread with my right hand, and thread on the left hand side. I hold it with my left hand, long thread. Now you camera close, show me the knot, center of the screen, show me the knot. So now I'm just moving it, pulling. Can you see something is changed? Yeah, just pulling, I just making the straight. So now I'm coming here, I can slide the knot. Can you see this? So this is, oh, okay. Oh, thank you, sir. So this is, I convert the square knot into slip knot. Can you see this? Yeah, after that you can make multiple knots. Yeah, it is, no, it is all suture, but ethibond will be better, but also all monofilament it will be there. This is not monofilament. Monofilament it is easier. Usually we used to get like this in monofilament only. I used to tell to my softeners, I'm going to do magic. No, no, no. So it is like now loose knot become tight. So I'm going like this. So again I'm going to that side. The lever is coming way. So you have to shift the lever retractor like this. So this is the vagus, pushing the vagus. Now you can see the fundus of the stomach. So I'm taking sticks. In the toupee, we have to fix the fundus to, sorry, door we have to fix it to right left crest, but here is no need to fix it to left crest. I'm taking a thick stick on the esophagus muscle wall. So making a C loop also, that also I'm telling you now. So if it is like this, if you hold like this, it is not, C is not formed. So hold like this, C is not formed. You can see I'm just rotating the needle holder. So C loop is formed. So keep your instrument, don't touch the surface, don't move the left hand instrument. Right hand instrument is moving, going and making a wrap. Okay. Then both the instrument is going towards the tail end. I rotate my left hand instrument little bit. Then I'm sliding the thread. Then tightening it. Then I'm holding with my left hand. I'm making, see, it is not C loop. Just turn, it become a reverse C. Go under wrap. Always reverse C will be, should be under wrap. Should not be over wrap. So after that, we can make like a regular way, we can make knots. Already 2 knots made. This is the third one, fourth one. 4 is okay, or we can make it one more. Usually it comes with two end thread. So only one half we are using it. And if you want, we can take another also. It's a very length thread. So again, hold this thread for a guidance. So that is a OG junction area pad. I'm avoiding that. So another one pitch. Then after that, you can go for a AIR side. Yeah, chloroplasty anterior. I'm doing it. Yes, yes, yeah. That is compulsory because all 5 port at the end of the surgery, I'll suck everything. Make a dry gauze and then I'll take it out. And I fix the. No, sometimes I fix the uh, that the fundus to right crest also to avoid the tension. But actually, it's no need because 6 suture is already there. The fundus is fixed with the esophagus, and that I made it little bit tight. That suture. Suction. 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 Yes, yes, yes. Yeah, anterior, sir. Because posterior, no, if I do that, esophagus become lifted. See, this is the final picture of myotomy, and the anterovagus is here. The entire mucosa is exposed, and the muscle is getting widened because of this suture. So this is yes. Post. No, no, your voice is breaking. What is the question? Okay. No, it is crura to be repaired. Always, most of the time, posterior. Most of the time, I do like this. I do like this. This case, if I do crura repair like this, you can see esophagus is little bit elevated, little tenting. Yeah, tenting of esophagus. That's why the lie is straight now, I'm going for anterior. When I see this, obviously you can see here is a defect, here it's not much. So that's why I'm doing it here. But normally the posterior we will do. And many surgeons are not doing it at all. It may also produce some dysphagia like, but it is not producing dysphagia because a lot of space is there. I'm doing only small one. And if I suppose if I want to do anterior crura, the posterior crura before myotomy, I'll finish the crural repair also. This case, since it is not much defect, I'm not doing it. So all the things to be done before myotomy. After myotomy, that not be nothing. So again, this side, right crest, clean lens. Yeah, he's doing fine. And even extubator on table. And we are shifting to, yesterday he was in ICU, HDU, now we are shifting to ward. Yeah, he's fine. So I'm not taking this, no, too tight, just for approximate one is enough. And you observe, no, I'm not using much cautery for myotomy, so that mucosa is not at all exposed to the heat. Even a delayed perforation transfer is also secondary, also is less. So that's why, this thing is adventitial covering layer to be taken down first, then longitudinal to be separated, then circular fibers just divide. Most of the time, no need for cautery. So with this, I'll finish. Uh, and this also, I'm going to take one more here. Okay, thank you. Yeah, thank you so much. Thank you so much. Thank you so much. Thank you. Yes, listen. Yes, LS become a gold standard. Yeah. So why I mentioned like that, many surgeons now they have to learn, and then they start failure. Poem is lot of no reflex tendency is so high, more than 50%. And here no definitely will not be any reflex because we have done a fundoplication. So since it is a gold standard technique, if all the surgeons are started doing, it is no the patient much benefit to the patient. So it is a gold standard technique. Thank you, thank you so much.